Proceed rapidly because I understand that there is a problem with time. Thanks for the invitation to the GEA Heart team, which is pioneering the field. On behalf of the Heart team of Evangelismos, I will present the most extraordinary case of 2024 in our hospital.
Dr. Triantafyllou, we can't see your presentation. We don't see your presentation.
Okay, I will do what's necessary. Okay. So can you see it now?
Not yet. Not yet.
I have done share screening.
Okay. And now you can do full screen.
Okay.
Now.
Okay.
Okay.
Okay, so I proceed. It's a complication management TAVI case. It's a usual case of TAVI, a 78-year-old male of average body habitus, of course, with shortness of breath and some syncopal episodes as symptoms for a severe aortic stenosis. He has also atrial fibrillation and peripheral arterial disease. A patient who was diabetic, hypertensive, and dyslipidemic. His ECG showed the atrial fibrillation with a short, with a QRS duration of 70 milliseconds and no other abnormalities. His ejection fraction was 65%. He had an aortic valve area of 0.87, some aortic regurgitation, and nothing very ominous other than that. His Euroscore 2 was calculated at 4.28%. So this is the CT analysis, an annulus of perimeter-derived diameter of 26 millimeters, similar dimensions of the LVOT, an elliptical annulus and LVOT with minimal diameter around 22 and maximum around 30. We had some, but not a lot, calcium at the leaflets. No other problems with the space of the sinus of Valsalva or of the coronary ostia. The iliofemoral axes were free of calcification and sufficiently wide and without tortuosity. So our heart team decided to treat the patient with a novel platform, the Allegro valve of 31 millimeters. These are the characteristics of this valve: self-expanding supralunar bovine pericardial valve with unique stent frame shape, some tailored radial force with pole movement, gold markers to guide the implantation depth and commissural alignment. It offers, in theory, single-digit mean gradients and high effective orifice areas, maintains coronary access, and due to these characteristics promised, we tried this valve, which has a different deployment system than the other self-expanding valves that we know. So this is the beginning of the procedure. After echo-guided puncture, we check angiographically as well. We see the 3-cusp view that is correct. So we do a pre-dilatation as premeditated with a 24 millimeter balloon. And then we start with a permaflow system and start with aiming the correct height of implantation, as you see to the right. With the last movement is to pull, not to push as for accurate, for example. We have to pull as the last movement to find the correct position. Then we press the button of release of the inflow, but the valve moved lower than expected. And when we release the button to make the nose cone come up, the valve went even further. So our next move was to try to pull the valve and, like a parachute, squeeze it in the annulus. We thought that we found the correct position, shown to the right. But when we did the final release, you will see what happens. Pop in. So the patient remained hemodynamically stable, and we had the time to try snaring. A snare which came from the inner curve achieved the higher position, luckily. A second snare because it distorted the outflow part of the valve. Then we saw that when we released the snares, the valve went too low. And we tried again only with a snare coming from the external curve, which also distorted the valve and did not achieve a good position. Then we tried, we decided that the best option was to snare from the inner curve, go as high as possible cautiously because everything was against resistance, and post-dilate the valve in order to stabilize it as high as possible initially with a 24 mm balloon, and then also with a 25 mm balloon, as shown to the right. So this was our hemodynamic result at the end under pacing, and this was the final angiographic result. The patient had an uncomplicated course and was discharged from the hospital 2 days later. There is a mild paravalvular leak, but considering the nightmare scenario, it was an acceptable result. We followed up the patient after the implantation at 1 month and at 6 months. The echo remained the same as shown here. There is a TP implantation, but only mild paravalvular regurgitation and no other problems, and very good hemodynamics. So to conclude, we had a problem maybe with the balloon expanding platform. We might have a smoother implantation procedure, but that was our choice, and we had to deal with the problems that we met down the way. Ventricular migration is a rare but potentially lethal complication, and having as possible solutions usually surgical valve retrieval and surgical aortic valve replacement. Other case reports mention implantation of a second heart valve with embolized heart valve in the LVOT. And another option, which could not be done in our case, was snaring the first valve into the ascending aorta and implanting a second valve in the correct position. We presented how an alternative technique adapted to our case worked, as described. The factors that contributed to the successful resolution was the relative hemodynamic stability of the patient, which gave us time, and maybe the flexibility of the outflow part of this particular self-expanding valve. We don't know that, we think that the result is not reproducible for this scenario if it happened again. Thank you for the attention.
Thank you, Dr. Triantafyllou, for the very interesting case. Really, this is the nightmare of an interventional cardiologist with cases like this. Do you think that if you are going to choose another device, you are going to have the same problem? It was because of the device, the pop-in problem that you presented?
The large edition of this device is a little bit hard to predict how it will function when you try to deploy it. The 23 and the 27 millimeter dimensions of this valve are more predictable. Anyway, for larger annuli, I think that balloon expandable valves are better choices in general. But for this case, there should be, if one selected a self-expanding valve, maybe a self-expanding valve with the possibility to reposition would make things much easier. This platform is promising to have a new released mechanism, which will be similar to the devices that we know, that will give the opportunity to reposition, receive, etc., while if you don't have the correct height. But it's not here yet. And yes, I agree that maybe with another platform, probably with another platform, we would have a smoother procedure.
Okay. Dr. Taleb?
Dr. Triantafyllou, congratulations, first of all, for being able to handle the situation there. Your case actually highlights exactly the purpose of why we do conferences like this and why we all want to get better. Because the more complex cases we do, the more complications we're going to see, and learning how to handle them adds value to our jobs. A general comment: you have to be good, but a little bit of lucky too, as mentioned earlier, because you were lucky enough to have a stable patient while all this was evolving, and especially popping into the ventricle is something that you cannot really do much if it is deep enough that you cannot get it out. You have only one option, and send them for surgery. But being good and being lucky is the best combination, so congratulations.
Okay, thank you, Dr. Taleb. Because of the time, we're going to thank you, Dr. Triantafyllou.